or last, well, a couple weeks ago at this point. So I'm just trying to remember exactly what was on everything here. But we have a few to go over from last time that we didn't quite get to, and then we'll go over another like nine or so cases, I think. And then we have one more part afterwards. And then after all that, I'll put together a bit of a sort of a summary review that'll probably go in the last part that just kind of summarizes everything. Okay, so if you want to go ahead and get started recording, if you're not already, go for it.
Yeah, you started.
Okay. All right. Welcome back. Okay, so we are getting right back to it with slide 10 here. I think we had seen desmoid fibromatosis before. So let's go ahead and get started with number 10. And I will go ahead and move this over and you can take a look. Okay. All right. So who wants to start us off? Location.
Probably somewhere skin,
Yeah, we're in the skin. All
more
right, we got a skin
superficial.
lesion. Okay, so let's take a look a little bit higher power. So what do you want to talk about first in terms of course, we go through our usual spiel, right? So the borders, architecture, cytology, in that order. So what about the borders of this lesion?
Yeah, it looks like an infiltrative lesion.
Yeah, it's infiltrative. That's true. That's true. It's kind of most of it. This whole slide is lesion, but you can see it's infiltrative. Okay, what do
And
you
it
think about
looks,
the infiltration?
yeah, it's infiltrating into the fat, and then it seems like there are some areas of fat that are entrapped within the tumor.
Yeah, that's true. That's true.
Yeah,
You got some entrapped fat. That's true. Okay. All right. Let's take a look at I guess if you look at how it's kind of going in between the fat and stuff, that's also important, right, for this case.
yeah.
But just kind of keep that in mind for now, and we'll come back to that. Now let's talk about architecture. We come down in, take a look at these cells. Let me see if I can find just a spot here that here, I will do it this way. We'll come over here because it's a little more cellular over here. Okay. What do you think about architecture?
So I see fascicles going in different direction. So if I
Okay.
had to pick an architecture, I'd say it's a story-form lesion.
Yeah, it looks like story form architecture, right? So you see a lot of story forming throughout, right? So somewhat a little whirling, a little story forming. So you kind of see it's at least there's lots of this kind of like um, cartwheeling around, right? So when we say story form, we mean that the architecture is there's like a central area and it's got like little rays coming out off of it, right? So that's what story form means here. So that's fairly typical architecture. Okay, let's talk about cytology. What do you think?
Yeah, looking at the cytology for these cells, it looks like a fibroblastic, myofibroblastic. I see these bland spindle cells.
Okay, pretty
Uh,
nondescript, bland looking spindle cells. That's true.
Yeah, they have this kind of open chromatin. I don't see any nucleoli.
Okay, yeah, no
Yeah,
nucleoli, just kind of like somewhat pointy on the ends, and that's it. Okay, fair enough, fair enough. Some areas are a little bit more cellular, but mostly just kind of relatively bland looking. All right, so what are your thoughts?
yeah, I don't see any mitotic figures or anything like that. I don't see any areas of necrosis.
Okay,
Uh, Given that it's a superficial cutaneous lesion with some entrapped fat, it has this storiform architecture. And then the entrapped fat itself, it looks like a honeycomb. So putting all these things together, I think of dermatofibrosarcoma, protuberans, DFSP.
DFSP. Yeah, okay, that's true. That's correct, and that is exactly what we're looking at here. So you mentioned that exactly what we were talking about. This sort of this pattern of infiltration is called honeycombing or septal type infiltration into the fat. Um, that's very typical of DFSP. DFSPs as well, generally, they will kind of come all the way up here to the surface. There'll be a little bit of like a space. It's called the Grenz zone, Grenz, whatever, Grenz zone, and then usually it's not associated with like excessive kind of overlying pseudoepitheliomatous hyperplasia. And the reason I mention all these things is because what's the major differential with DFSP? Here's more of that story forming, by the way. What's the big differential?
Dermatofibroma on the lower end, and then on the upper end is sarcomatous transformation.
Right, so dermatofibroma, right, or also called benign fibrous which we'll talk about in another lecture for sure. We'll go into more of it, but DF is the main one, and generally it will have very similar appearance where it'll have a lot of kind of story forming and whorling. That's fairly typical. Towards the edges, it may be somewhat infiltrative around the dermal collagen, where it'll kind of wrap around the dermal collagen, but it generally won't have that subcutaneous extension where it'll be sort of septally infiltrating into the subcu like DFSP does. And then usually the overlying is quite hyperplastic, actually. All right, well, that's good. Okay, let me see if I think I had a couple more examples. Here's another one. Again, very infiltrative into the fat. And this is one example that may have a little bit more mitotic activity. So here's a mite right there. The thing about what is your kind of like, how do you think about fibrosarcomatous transformation? What do you guys expect there?
It becomes less. It becomes less storiform and more um what's the word? Sorry, I'm blanking.
Like a
Um,
herringbone.
Probably
yeah, herringbone. Yeah.
something like that. So that's one thing that you expect to see, not always, but yeah, you can expect to see that architecturally it changes from storiform to more fascicular. What else?
The atypia and CD34 expression will change. It
Right. So
becomes more atypical.
they tend to be more atypical. That's true. So the cells tend to be more plump, more hypercellular, so even more kind of cellularity close together, more plump. CD34 can kind of be reduced or lost. It's just kind of like a bit of a iffy marker, to be honest. I've seen it in a number of DFSPs, and it's just not always a great thing, to be honest, to look for. But another good thing to keep in mind is mitotic figures. This one, for example, this area is a little bit fascicular, right? And the cells are a bit bigger and kind of more plump. Is a bit fascicular, but also generally fibrosarcomatous DFSP is going to have somewhere like more than 4 to 5 mitotic figures per high power field or per 10 high power fields, right? So usually, you're not really going to see fibrosarcomatous transformation in anything less than that generally. So that serves as like a decent cutoff as well. So, we can actually see 1, 2, um, you know, 3 right here, maybe another one elsewhere. So there's several in this one. So this is enough generally here to call fibrosarcomatous transformation as well.
Mm.
Often fibrosarcomatous transformation is ends up being relatively more well circumscribed in those areas rather than kind of like the areas where it's more infiltrated and coming out in tongues. The fibrosarcomatous transformation area is often kind of more well defined and circumscribed. Sort of looks like a sarcoma, right? I think I have another one that is a little bit better. Here we go. This is an area here where you can see the infiltration into the fat, right?
Yeah.
And it's quite cellular, very hypercellular, very plump cells, and architecturally very much kind of much more fascicular. And you can see that there's lots of mitotic figures. This
Mm.
area is a fibrosarcomatous transformation. We know that this is DFSP because it has the fusion, right, which we'll get into in a second. But one thing I want to show you alongside this one, the less fibrosarcomatous areas looks like this. What's going on here?
Has this myxoid change?
Myxoid, yeah, it looks like
Myxoid
bluish.
change. Yeah, very
Yeah.
myxoid, right? So this is a known variant for DFSP. It's called myxoid DFSP, right? And when you look at it, like if you're just to look at this without all that other stuff, without me giving you all the other stuff, you might think like, could this be myxofibrosarcoma? Could be
Mm.
some sort of low-grade fibromyxoid sarcoma. It's kind of interesting. It's weirdly like diffusely myxoid. And indeed, that tends to be the most common differential when you think about that. But don't neglect to think about myxoid DFSP as a possibility, right? All right. Perfect. Okay. Did I have anything else? I don't
How
know.
would you describe these vessels here in this myxoid area?
The vessels in here. So,
Yeah.
right. So DFSP's vessels are not, there's nothing like fairly classic or typical, right? There's
Mm.
no pathognomonic vessels for DFSP. And this is another reason, like, you can kind of hallucinate that these are sort of curvilinear, blah, 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 like myxofibrosarcoma, which we'll talk
Hmm.
about later. And like you can kind of hallucinate that and just kind of make it up that that's probably the like a myxofibrosarc or something because of that. But there's canonically no real like our typical vascular pattern for DFSP.
Okay.
We'll go over what curvilinear vessels are in a bit. Cool. And I think this last one is just to show kind of, this last one is one final variant. What is going on here? What's this stuff? See, of course, it's quite infiltrative still. It's
Like
a skin biopsy, but what is this stuff?
hemosiderin.
Hemosiderin? Not quite.
No.
Could be a thought. It's a thought. What else?
Could be melanin.
Yeah, it could be
Right.
melanin. It's kind of chunky.
Melanin. Yeah, melanin pigment, exactly. So this is melanin, right? And do you know what this is called?
I'd guess pigmented DFSP or
It-
melanotic
It's true.
DFSP.
It's called a
Melanotic.
pigmented
Melanotic.
DFSP. There's a name for it. If we don't want to like neglect giving people their due, I suppose. It's called a Bednar tumor. So
That
it's named after a guy named Bednar, I guess. But anyways, so pigmented DFSP. This is kind of like a big thing, all right? Because it's a skin tumor. See melanin pigment. Well, it's got to be melanoma, right?
right.
You can get pigmented DFSPs.
Noted.
Cool. All right, I think that's it for that. Let's take a look at the roundup here of the information. So DFSP, big thing about DFSP is one cutaneous tumor with sub-Q infiltration. That's kind of a requirement. Generally, it's going to be a cutaneous and sub-Q mass, right? These things are very locally aggressive, right? You can imagine it's infiltrative. It's going to be very locally aggressive, but they're usually non-metastasizing. So even though we call it Dermatofibrosarcoma protuberans, it's usually you don't see the you don't really see it metastasize without fibrosarcomatous transformation. And once you do, the met rate is about 10 to 15%. Actually, you can grade it. Grading is a little controversial for DFSP, sort of fibrosarcomatous DFSP, because the grade doesn't quite correlate to the metastatic risk, So they're all kind of like somewhere like relatively mild metastatic risk for fibrosarcomatous DFSP. Okay, and they're generally in younger to middle-aged adults. Natural history for these things is generally a very kind of like slow, persistent growth because it's locally recurrent. It may have like multiple recurrences, and then eventually it turns into fibrosarcomatous DFSP. A small subset of them will have fibrosarcomatous DFSP at outset too. So the good news is generally surgery is still the option, and depending on your hospital and your system, there is very much like a particular way that people will do this. But a wide local excision, patients do really well, particularly if you use Mohs to like assess margins around it, right? So that's what we do here, for example. They'll do Mohs microsurgery to assess the lateral margins, and then the deep margins, all that's left to assess later. But with that, generally most of the time you won't have recurrences if you give a wide local excision. Okay, so your histologic criteria, like we said, needs to be hypercellular tumor, monomorphic spindle cells, generally sort of storiform architecture. Those are kind of required. Septal infiltration into the subcutaneous fat. And like we said, additional features, you can have melanin pigment and Bednar tumors, myxoid changes. You can actually have myoid differentiation as well in DFSP. And I talked about the criteria for fibrosarcomatous transformation already. You're looking for an area that's kind of higher cellularity, cytologic atypia, that kind of thing. Usually there's more mitotic figures, kind of more than 4/10, in often fascicular herringbone architecture. The big IHC for this is CD34, right? So these things are diffusely CD34 positive, which is nice. Kind of helps you distinguish between benign fibrous histiocytomas, right, and DF. Yeah, but as you guys mentioned, it can be lost in fibrosarcomatous transformation. About half the time, to be honest, I see it a lot of times that's still positive. So, but it can be lost. So just know that. Yeah, classically these have a fusion, right? So these are fusion-driven tumors. So all things considered, if you're still looking to figure out what it is, or if you're studying for your boards, for example, this is a very common question that you might see. It's PDGFB COL1A1 fusion is what's involved in the vast majority of them. Sometimes it's PGDFD. Sometimes there's some variant fusions with like EMLIN, EMLIN1, PGDFD, that kind of thing. So, but the vast majority are COL1A1 fused. So you can do FISH for that, or you can do NGS, which is what we do. Cool. Any question about DFSP?
Yeah, I have a question.
Yeah, go for it.
When you're doing or seeing the fibrosarcomatous transformation, how, in your experience, does it present? Is it like a little blip of it with the high mitotic count, or is it like, span a couple low power fields? Like how does it usually present?
It depends. Most of the time, I would say it's a pretty decent chunk of it that is
Okay.
fibrosarcomatous once
Okay.
it starts having it. But you can have focal areas, right? Where you have a very large tumor and
Hmm.
you have like a corner of it that's like fibrosarcomatous. I'd say, you really need to assess the whole tumor, right? Not like
Okay.
don't submit the whole tumor, but you really need to
Right.
assess like 1% actually like look around the whole tumor and
Yeah.
kind of see is there anywhere grossly you're really not going to you're likely not going to see a whole lot of difference grossly when you look at it. So it's not going to be that easy to just kind of like pinpoint areas that
Mm.
could be fibrosarcomatous.
Mm. So any amount you say with fibrosarcomatous
Yeah.
transformation. Okay,
Yep.
got it.
Yep. Any
Cool.
amount is fibrosarcomatous. Yeah.
Got it.
Cool. All right, moving on. Oh yeah, I don't have a picture for I don't have a slide for this one, but this next one, but we can just kind of jump into it real quick because this is a more of a children's tumor, so I don't really end up. I don't see these very often,
Sure.
and there's generally a relationship with DFSP with this tumor, so I wanted to talk about it here. So giant cell fibroblastoma, it's we think it's closely related to DFSP. One because it has the same fusion, so that's something to remember. Um, but two, because we have seen some cases where it's sort of like where there's a transition from one to the other. So that's been
Oh.
described as well. Predominantly in kids, usually around, their first decade of life, basically.
Mm.
The thing about giant cell fibroblastoma, these don't met generally, but again, similar to DFSP, they can have a high risk of local recurrence. I do have some pictures that I can show, but we'll talk about the histologic criteria first, and then we'll move on to that. Again, they're very infiltrative, like you'd expect. They have a pretty bland spindled stroma, that's kind of collagenous to myxoid, right? And then the big histologic feature is that you're going to have these stellate to multinucleated type giant cells that line ectatic looking pseudovascular spaces. Like I mentioned, you can have hybrid areas with DFSP. They're going to be 34 positive as you expect, and they have that same molecular. But let me show you exactly what that looks like. You can see here it has these sort of like pseudovascular type ectatic spaces, and the giant cells, these kind of monster cells here, they kind of line that, right? So that's very typical of giant cell fibroblastoma. Here's another one. You can see the giant cell fibroblastoma area here, and then adjacent to that on the right is the DFSP area. So that's a hybrid, right? So again, kids tumor. I don't get to see a lot of these, but very fun to know about. All right, let's move on to the next digital slide. Let's see, where are you? Okay, sweet. Okay, let me set this up here. All right, we'll start with. Let me move this. Yep. Okay. So who wants to describe this one? I guess low power, it's kind of very hemorrhagic looking, but let's kind of aim at these areas. How about that?
Yeah, it looks like a very cellular lesion.
Okay, pretty cellular. That's true. That's true.
Yeah, what's catching my eye, two things. First of all, it looks like we do have a lot of blue cells. And then
Okay.
secondly, we have like thick-walled blood vessels.
Yeah. So there's bluish cells. There's some thicker
Mm-hmm.
wall blood vessels. That's true.
Mm-hmm.
That's true. Okay. What else do we see here? What's going on here?
It looks like we have some staghorn vessels.
Staghorn blood vessels. That's true. Okay. All right. So what kind of tumors have staghorn blood vessels?
I
Right
can
off the
think of,
bat, let's go into it here. Let me put an area here that's a little bit more representative. So what
Oh
else do you
yeah,
see,
yeah.
by the way? What is all this stuff?
a lot of collagen.
Collagen. Yeah. So a lot
Looks
of
like
collagen in the background.
extravasated red blood cells.
Certainly a lot of hemorrhage with this case. That's true. But this is kind of a classic look here. So,
Mm.
rather plump looking cells in this case, but again, nice collagenous background, right? These big collagen bundles, and then these sort of staghorn type vessels. So let's talk about staghorn vessels. What tumors have staghorn vessels? So Rao is coming back to we're coming back to this.
FT.
Okay, so the answer is every single tumor under the sun
Uh,
could have staghorn. Unfortunately, this used to be when I was a resident, we used to learn this. We would when I was a first year, we'd have a short list of like
oh dear.
6 tumors that would have staghorn vessels or something, and then every year that I went up as second, third, fourth year, we'd add tumors to it essentially. this is what we keep track of for Dr. Rao when we were actually learning from him.
Oh,
Okay, but there are some cases, there are some tumors that classically have staghorn vessels. So what are the classic ones?
Solitary fibrous tumor.
Solitary fibrous tumor, right, which is also used to be called hemangiopericytoma, which is also where we get hemangiopericytic vessels, which is staghorn vessels, right? The two are one and the same. Solitary fibrous tumor. Okay, what else? So it's unrelated to like this tumor, but what else can have staghorn vessels? That's kind of classic.
Synovial sarcoma.
Synovial sarcomas. Yes, that's true. Okay, what else? So I guess
Extraskeletal myxoid chondrosarc.
extraskeletal myxoid chondrosarc. No, not that one. But you have one of the words right. There is one that is similar to that. Different tumor, right? Extraskeletal myxoid chondrosarc is not really the same differentiation, but we're talking mesenchymal chondrosarc. That generally has.
Oh, yep, that's definitely what I meant to say.
Yep, exactly. What else? Anything else? Classically, okay, phosphaturic mesenchymal tumors classically have staghorn vessels, juxtaglomerular tumors of the kidney, this staghorn vessels, that kind of thing. There's just a bunch of like random junk, right? But they all kind of have those as nice vessels. But the big thing is that just about any tumor can have any soft tissue tumor can have staghorn vessels. All right, but what do you need to diagnose an SFT?
Stat 6.
Okay, stat six helpful, right? Morphologically, we're talking about now kind of what do you need? What do you expect to see when you look at an SFT morphologically?
It's monomorphic cells.
So they can be monomorphic, yeah. They can be. They're relatively nondescript spindle cells, it is a fibroblastic tumor, right? But what is the big background that you expect to see with these tumors?
Collagenous background.
Collagenous, right? So classically, they have to have a very collagenous background, or they have to have some amount of collagen, right? And exactly what Heather's kind of pointing out, architecturally, they have a very patternless growth, some people call patternless pattern, to be as obnoxious as possible, but basically they don't have a right? But really good, Heather, yes. So they'll have that kind of patternless architecture. You don't really see a good architecture here anywhere, right? It's just kind of leaps from various other things. And usually at least focally some collagenous type background. So sometimes the thing is these tumors have a very wide spectrum of morphologies, right? And we'll talk about that a little bit more in a second. But you did say you wanted a stat six, so I think I do have a stat six for this one. And here's your stat six, and nice and positive. What is stat six? What's this from? What is the reason? Why is it stat six positive?
It's in a part of the JAK stat pathway.
I think that's stat three is what that was Jack's. I don't remember. But I don't think I don't know if it's related to that. But the idea is that is this sort of a molecular adjunct stain, right? So there's a fusion that involves stat six, which is with what partner?
NAB2.
NAB2.
Exactly. Perfect.
NAB.
There you go. Stat six, NAB2. I think that is, I think I have more later, but let's take a look at the info here. All right. So SFTs, wide age range, can occur any location. We used to think of these predominantly as sort of like a pleural tumor, right? A pleural-based tumor. To be honest, pleural-based tumors are kind of the minority nowadays. But we used to think about like they were pleural tumors. We actually used to call these fibrous mesothelioma. But that's all kind of gone away. The thing is, there's a lot of different morphologies for this. So they've been called many different things in the past, but they've all been kind of like lumped in together to one tumor based on the fact that they are driven by this NAB2 STAT6. So very common other locations include the CNS, which luckily we have Heather with us here, who is our neuropathologist, who's seen probably hundreds of these in the brain at this point. And then extraplurally as well throughout the soft tissues, organ systems. You can see them in the liver. Actually, interesting story. They're pretty rare in organs overall, but you will see them occasionally. Actually had a frozen for one as a first year in the liver. I told the GI fellows at the time, I was like, well, it's probably just a solitary fibrous tumor in the liver. And he's like, that's probably like the one time you'll ever see that in your life. But joke's on him. I've seen several now. 'Cause he didn't know. He
Stop.
didn't know what I would be doing in the future, I guess. But yeah. So liver is not horribly. It's very rare to see it there, but you can see them throughout the GI tract. Okay, so local recurrence for these is possible. All SFTs have some potential malignant potential, but we judge whether whether they're likely to met by using a risk stratification model. It's called the modified D'Amico risk stratification, named after Dr. D'Amico, um, and um, and basically it's based on patient's age, tumor size, mitotic activity, and necrosis. Low risk tumors basically are not going to met ever, but intermediate to high risk tumors have a metastatic potential. Um, oh, this is one other thing. SFT, this is a kind of a boardsy type question, but you'll run into this like very rarely. Some SFTs produce a paraneoplastic syndrome called Doge-Potter syndrome, and production of IGF-2 that leads to hypoglycemia. So some SFTs, those patients will actually develop hypoglycemia, and that's their first presentation. So just remember that for boards. Okay, so like I talked about, there's a spectrum of morphology, right? So there's the fibrous type, which we used to call like fibrous mesothelioma. It's very collagenous, right? Very hypocellular, bland, fibroblastic, highly collagenous and sclerotic background, staghorn vasculature, right? Then there's the hemangiopericytoma-like, and to be quite honest, a lot of the CNS tumors, SFTs, kind of still look like hemangiopericytoma-like type, but they're much more plump, hypercellular, kind of that haphazard patternless architecture. But there are still kind of like intervening kind of bundles of ropey collagen that you'll see, staghorn vessels, right? Here's some additional features. You can get lipomatous features in these things. It's called a lipomatous SFT, and it can be very confusing, right? But think about it, right? So you'll have a dipstick metaplasia. These things can have very variable amounts of mitotic activity and necrosis depending on their risk. And there's supposedly this kind of like connected lesion called a giant cell angiofibroma that has somewhat of a similar look to giant cell fibroblastoma in that they're these sort of like giant cell line pseudovascular spaces. So that I don't tend to see very often, but it can be. And then lastly, these tumors do have this weird predilection to dedifferentiate to a high-grade sarcoma, right? So that is a possibility. Okay, so like we said, these things are going to be diffuse CD34 and they'll be STAT6 positive, and the molecular will be STAT6 fused in the vast majority of them. Here's some additional SFTs to look at that I put together. Just a couple of
Let's
additionals here.
go.
Here's one.
A sift.
There you go. This is the problem, right? So
Oh,
look at this thing. It's probably some sort of a dipstitic type tumor, right?
yeah.
Look, there's a lipoblast there.
Oh, no.
Yeah, this is lipomatous SFT, right? So this is a big problem. Just kind of look at the background cytology in the cells, and you see that there's this kind of more plump hemangiopericytoma-like background, and there's collagen. You really just don't want to neglect thinking about it. In a tumor that you might be wondering about, could this be some sort of weird like spindle cell or pleomorphic, lipomatous tumor of some kind? Think about getting STAT6, right? Let me see if I have, this one didn't even really have the best staghorn vessels, but there are some here that you can see this kind of branching, right?
Mm.
Okay, and then I think this one is an example of a dedifferentiated SFT. And you can see that, let me see if I can find an area where's the pleomorphic area? All good. Let's see. Oh no, maybe not this one. Hold on. Oops. Not this one. This is just showing you the sort of more hemangiopericytoma-like pattern where it's just kind of this more cellular appearance, right? And then I think, do I have oops.
Oh, yeah, so cellular.
Do I have one I do, I think I do later. But anyways, this is the SFT risk stratification, which you can see. This is the nomogram for it that we use. And like I said, it's based on age, size, mitotic count, and necrosis. You can always pause this later and look at it yourself. Okay, this is the slide on dedifferentiation. Again, it's transformation basically of an SFT to a high-grade sarcoma, right? So you're going to be looking for areas of like moderate to marked cytologic atypia, pleomorphism, mitotic activity, or like increased mitotic figures in atypical mites, and tumor necrosis, kind of more akin to just a high-grade sarcoma rather than an SFT. These tumors can show loss of CD34 staining. They can even show loss of STAT6 staining for whatever reason, but often are still STAT6 positive. Here we go. Here's my example of DDIF SFT. You can see the background here. It's already starting to get quite cellular. Oops. Hold on. Sorry, there we go. Okay, the background here has this kind of like staghorn collagenous background, and then this other piece has a transition to a high-grade pleomorphic sarcoma. So lots of pleomorphism, lots of mitotic activity, and there was a lot of necrosis in this too. So there you go. That's DDIF. So that's an important thing to not forget, right? Cool.
Is DDIF SFT the same as malignant SFT?
No. Well, okay. So I don't use the term malignant SFT, and I think we don't do that anymore. So it used to be the thing where we would call malignant SFT if it looked kind of higher, like there are more mitoses and blah blah. Those we generally will call like high risk SFT, right? So they'll be SFT and they'll be high risk, right? I only call DDIF when it becomes a high grade sarcoma. So if it looks straightforward, like monomorphic, still like an SFT, just lots of mites, I don't call DDIF, all right? I don't call malignant or whatever, because all SFTs are technically malignant. So that's the distinction. So that is true. We used to do that at times. Okay, cool. All right, digital slide number 12. Let's keep moving. And sorry, guys, I know we had to start a bit late, so I understand if things people have to kind of move in and out. Let's see. Here we go. I think I may have wanted to start with this. Oh yeah, here we go. Okay, so ignore the giant hole in the middle. It's just kind of from histology process happens. But okay, so does anyone want to describe sort of architecturally or sort of circumscription, borders, and everything? Where are we exactly?
It's a well circumscribed
Okay.
lesion in the lung,
In the lung, yeah. So we're in the lung.
and it's not encapsulated, but it's definitely well circumscribed.
Yeah, yeah. Well circumscribed, non-encapsulated. Let's take a look at the architecture. What do you think about this? Let me stop at a spot for it here. What do you think about this architecture?
It's almost alveolar like or acinar.
Well, so there's a lot of discohesive stuff in here, and I think that might
Yeah.
be a little weird, but the main kind of like cellular type has kind of these little fascicles running through as well, right?
Yeah.
But there's a weird cytology component to this. What is all this stuff? Are these all the tumor cells or what? What do you think is going on here?
There's a heavy lymphoplasmacytic infiltrate.
Yeah.
Yeah, exactly. It's full of immune cells, basically. So lots of lymphocytic cells, lots of plasma cells. And then intervening in those areas, you do see this kind of like background spindle proliferation. Okay. All right. So what are your thoughts? Here's kind of like some of the more spindly areas, right? So kind of nondescript looking spindle cells, maybe some inconspicuous nucleoli, maybe some
If
stuff
I
like
got
what's that?
Yeah, if I got this in real life, to be honest, my first thought would be that to look up the lymphoplasmacytic infiltrate itself. My first thought would be that would be the neoplastic.
Could be something. This could be a lymphoma, right? Could be thinking about
or a plasmacytoma or something.
hematopoietic. Okay, fair enough. Could think about that. Anything else? A lot of plasma cells. That's true. Yeah, exactly, Heather. So
Yeah, exactly.
good example here. This is an IMT. So inflammatory myofibroblastic tumor. This one's just extensively heavy with inflammation. Sometimes it has more, sometimes it has less. Usually it's lymphoplasmacytic most of the time. There's one variant that tends to have a more neutrophilic infiltrate, which we'll talk about later. Okay, so IMT, inflammatory myofibroblastic tumor. What do you want to do to prove it, by the way? ALK, that's right, right. So ALK1 stain is a good marker generally. Majority of IMTs that have an ALK rearrangement will stain with ALK, right? Now not all of them have ALK, right? So uh, only about like 60-ish% of IMTs actually have an ALK rearrangement, but those should all have ALK expression. Let me show you another example. So this is quite an inflammatory heavy one. This is a different one that tends to be much more myxoid, right? So you still do see some scattered inflammatory cells in here, but it's actually quite much more like prominently myxoid with this kind of myofibroblastic tumor cell background. This is actually another kind of tip. This is another kind of way you might see IMT. So don't just kind of rule it out just because it's not like screamingly inflamed, right? So sometimes it has this more myxoid look, right? And but you can still tell that these are kind of like myofibroblastic cells, right? They have this kind of stellate look, and you do see some scattered inflammation throughout. Don't neglect to think about it. Now, in case you're not believing me, this is the ALK stain, and
Ooh.
it's nice and positive, right? Okay, that's our IMT. Let's talk about it. And anyone have any questions so far, first of all?
I feel like the last one has these, what's it called? Curvilinear vessels.
I saw those
Right.
too.
Right, it almost has a bit of a like, oh, could that be
Yeah.
Myxofibrosarcoma? Maybe,
Yeah.
right? Right. Now that one was actually in the vocal cord, so it's not Myxofibrosarcoma probably,
Oh.
but there you go. Okay, so IMTs, these things often behave indolently, to be honest, but local recurrence and Mets are possible. They all have metastatic potential technically, if they're true like IMT. About 5% of those cases will Met, though it's relatively indolent tumor still. There's not really any clear prognostic markers for this thing. More common for these tumors in children, though you generally have a pretty wide age range. And you can get them anywhere, right? So typical sites tend to be like the lung, like we showed, or the soft tissues, but you can get them in GI tract, you get them in bladder, get them in the brain, but they'll happen anywhere. And they will have often a very sort of overlapping morphology with what has been called in the past like an inflammatory pseudotumor. And particularly in the lung, if you have sort of like old histoplasmosis infections or old fungal infections, and they cause an inflammatory background that's very similar to IMT. So that differential between like IMT and inflammatory pseudotumor in the lung is pretty big, right? And these things can actually be associated with some weird cytokine release, actually. So patients can get almost like B symptoms, right? Fevers, anemias, weight loss, and hypergammaglobulinemia as well. All right, but here's your criteria. Generally, you're going to see these fascicles of myofibroblastic spindle cells, a prominent inflammatory infiltrate, and the stroma tends to be variably collagenous to myxoid. Mitotic activity is usually low. You're not usually going to see much of cytologic atypia either. Sometimes, like you saw with the myxoid thing, sometimes the cells can be quite plump, almost like ganglion-like, similar to how myofibroblasts can do a lot of other, they can always look like that. Okay, and then here's this rare subtype that I mentioned before. It's called epithelioid inflammatory myofibroblastic sarcoma, which is kind of it's a very rare subtype, usually in younger patients, that has much more epithelioid morphology and is more high grade kind of morphology, right? It generally behaves worse. But they have a very particular thing. One, they tend to have more neutrophils usually, but does anyone know what the staining pattern is? So these are weird. They stain with ALK, but they have this sort of perinuclear, perinuclear staining, sort of like perinuclear dot-like staining around with ALK. Okay, as we can expect, it's going to stain with myofibroblastic markers. So SMA is your best bet. ALK1 is positive. Usually really the best, like most sensitive clone is D5F3, which we have here. That tends to be the most common one that is used. Sometimes it's different because remember, ALK is used for what other tumor?
Anaplastic large cell lymphoma.
Anaplastic, right? So your heme crew may be like, I like that other antibody more. So, there may be some differences, but most soft tissue places will use D5F3 or something like that. So there can be some variability with antibodies. But so anyways, and they're driven by ALK rearrangements. It could be with anything, right? It could be with a lot of different like genes. And then rarely they don't have ALK. Instead, they have like ROS1 or they have NTRK rearrangements or RETch or PDGFB, something like that. They still can be called an INT. Okay. All right. Any questions about these guys? What other ALK tumors do you know, by the way? There's actually quite a number that will stain with ALK. Weirdly enough, even though we think like, oh, it's got to be IMT, it's ALK, right?
There's a ALK-associated histiocytoses.
Exactly. I think Heather, you've looked at too many histiocytic
I
things.
know, so many.
Yeah, ALK histiocytosis, or sometimes called like epithelioid fibrous histiocytomas of the skin. They'll have ALK, right? So it's sort of an ALK histiocytosis. And there's also what's that?
Lung adenocarcinoma.
Lung adenocarcinoma, right? Exactly. But ALK rearranged lung adenocarcinomas.
Yeah,
Okay.
ALK rearranged renal cell carcinoma.
ALK rearranged renal cell carcinoma. So a number of carcinomas will be ALK rearranged. Yeah, yeah, that's true. And then there's a rare sort of rhabdomyosarcoma subset that it's called that'll have sort of like TCF fusions that weirdly have aberrant ALK expression for no reason because they don't have an ALK fusion. So whatever it is. So, anyways, it's not 100% specific, just so you know. Okay, moving on. Here's a picture, by the way, of the epithelioid IMS. More aggressive generally, and has that nice perinuclear ALK1 staining, which you can see here. All right, and as you can see, it's much more epithelioid almost, right? So big round cells, lots of neutrophils usually. Okay, last thing I want to point out while we're kind of in this vein is adult fibrosarcoma. I didn't pick up a case of this because I've never made this diagnosis, frankly. I don't believe it's real. This is controversial, I suppose. I don't know if some other bonus soft tissue pathologist wants to come at me. It's totally fine. But it's a bit of a historical diagnosis these days. It's still in the WHO book. You'll read it, whatever. But it's the vast majority of these cases that were called adult fibrosarcomas have been really figured out to be something different, right? You might imagine, what is the actual criteria to make this diagnosis? It's a spindle cell sarcoma that has fibroblastic differentiation and herringbone to fascicular architecture. We've run into many fibroblastic tumors that have herringbone to fascicular architecture, probably the most common being fibrosarcomatous DFSP, which is probably what most of these actually are. But you'll see that with like infantile fibrosarcomas or NTRK rearranged sarcomas, that kind of thing. They can some of these ended up being called like synovial sarcomas or solitary fibrous tumors. Basically, most of these tumors are reclassified now as some other tumor. And so this is still a diagnosis of exclusion, and I don't really see the need to use it personally. It's not significantly different from just saying an undifferentiated spindle cell sarcoma. It's really about human hubris of judging what is a fibroblastic cell versus what's just an undifferentiated spindle cell sarcoma, whatever. I'm sure there's some 80-year-old pathologists out there. It's like, I know what every fibroblast looks like. So anyways, that's the note about it.
He's gonna come for you.
I don't use it. So, I think most of us don't use it really, to be honest. It would be a very difficult diagnosis to make, and I don't find the need. So that said, infantile fibrosarcoma is completely different, which we'll talk about later. Okay. This one is not infantile fibrosarcoma, by the way, just so you know. That's actually going to be in next lecture, but we will start with this. Let's take a look at it. Okay. Here we go. Next slide. Okay, so I think it's I'll give you the location later. But what do you guys think? It is a biopsy, so let me point out maybe toward the edge a little bit here. What do you think about this? Circumscription wise, I guess.
Yeah, looks
Infiltrated.
Yeah.
Yeah, it's kind of ill-defined, right? There's fat throughout this thing, so it's a little infiltrative. Okay. Let's talk about sort of architecturally what we're looking at here and maybe the background.
Yeah, see this ropey collagen.
Yeah, really long
Okay,
band.
there's ropey collagen, right?
Yeah.
Ropey,
Eosinophilic.
that's true.
I
Okay.
see some fat I don't know if if fat is part of the lesion or not part of the lesion, honestly. Could be.
In the lesion, part of the lesion.
Answer is, I don't think anybody knows really. Okay, okay, that's allowed. All right, so then let's talk about the cells. It's very collagenous, kind of haphazard, but maybe there's some areas with somewhat fascicular look, but it's not, it's much more collagenous in this one, fairly
Yeah.
hyalinized, and cells pretty
And
bland, right?
yeah,
Small.
nondescript
Yeah.
glands in the cells.
Okay,
Ish.
Yeah.
yeah, exactly. What do you guys think? Any thoughts? What if I tell you where this is? That
Yeah,
might
I'm a
help.
location pathologist, but
You're a
if you
local
just
space pathologist, huh?
yeah, but if you just give me this picture here, I think probably I think something along the lines of like spindle cell lipoma, mammary type myofibroblastoma.
Okay, okay.
Some-
Well, what if I tell you this is a biopsy, right? And it came with 4 different slides with like 15 different levels, and it went to, you know, there were two like stereotactic calcification biopsies, and there's like a 3 hour long report that gets signed out after this. It's a breast biopsy, right? So yeah, this is from the breast, right? At least our breast team is very exuberant about their.
Thorough.
But yeah, this is from the breast. So what do you think? Most likely.
Myofibroblastoma.
Myofibroblastoma, exactly. So this is a good example of myofibroblastoma, and you mentioned a bunch of things that are kind of overlapping, and we're going to talk about all those in the next hopefully like 10, 15 minutes, and then we'll call it a day because there's a lot to get into. All right, so myofibroblastoma. Let me show you another example. Here's another one. This one is, again, a breast biopsy, much more cellular in this example. You can see a lot of spindle cells here, very hypercellular, but again, that kind of like hyalinized to collagenous background is very typical, right? It's these areas here. But again, quite relatively like, bland looking spindle cells. And it is very typical to also have admixed fat in these. That's not uncommon, right? And they tend to be pretty ill-defined. Okay, it's a good myofibroblastoma. Here's another example of one. This one, much more vascular. There's a lot of more vascular cells throughout it. But again, adipocytic cells throughout, kind of fibrotic to collagenous, ropey collagen to hyalinized background. Um, and this one actually has some more like staghorn type vessels, which is totally okay. Right. Okay, what do you want to do for this? How do you, well, morphologically, you could diagnose it, but any way you can kind of like aid yourself to prove it?
Yeah, I think you can do CD34, Desmond, and RB loss.
Yeah, so
Mhm.
CD34, often these things are kind of they're Desmond positive. That tends to be most commonly they're Desmond positive, but CD34 is often positive. SMA can be positive in a subset, right? And RB1 loss. So you can do IHC for RB1 if you want, and that can work. So this is an example of a myofibroblastoma. Benign tumors, these are totally benign. It used to be called mammary type, but we don't call it that anymore, right? Because they're not all in the breast, even though I just showed you. I mean, that last one was in the shoulder, I think. But the idea is that they often happen in this kind of like what we call like the putatively we call like the milk line. So it's like from like the nipples down to the groin, right? So they can happen they often happen anywhere in that region, but you can get them just about anywhere. But those are the most common locations, um, um, from the groin to the breast, basically. So we don't really call them mammary type anymore because you just see them anywhere. All right, so those criteria we talked about, usually kind of like these short fascicles, intersecting fascicles, myofibroblastic type cells or looking cells, hyalinized or ropey collagenous bands is the background, right? We mentioned you can have variable adipocytic tissue. You can also have a lot of nuclear palisading, actually. It looks like Verroque bodies. You can get those kinds of palisading changes. And you can get symplastic changes, right? So a lot of cytologic atypia. As we mentioned, usually CD34 and Desmond co-positive. And they may be ER and PR as well. That can be helpful. And loss of RB. And the reason for that is because molecularly you get loss of the short arm of or sorry, the long arm of 13, chromosome 13, right? So 13q14. So that area includes RB1. So we don't actually know that relates to loss of RB1 technically that's causing this, but it's lost and we can use that
Yeah.
as an adjunct.
Do they present with high BI-RADS?
Well, so
You know?
any sort of infiltrative lesion, for example, like fibromatosis in the breast or myofibroblastoma, there'll be a suspicious BI-RADS, right?
I
So,
see. Okay.
it's going to be at least a 4B, right? Because
Okay.
there will be, they won't be kind
All
of
the
like a
things.
well-defined, kind of like fibroadenoma look. So they're
Sure.
almost always biopsied because they're almost always suspicious. Cool. All right. Wonderful. Let's see what else. Okay, so given that, let's kind of go through and talk about some of these other ones. I'll kind of go through this one real quick, just because it's going to be very similar morphologically. This thing has a lot more vascular spaces throughout it, but
Yeah.
again, a very bland collagenous background,
Yeah.
bland collagenous cells. And let me show
Oh,
you somewhat more kind of like thicker walled vessels throughout as well. Yeah, and very kind of dense collagenous background. This thing is also around the groin. So if we had to put this to one name, what would you think?
Angiofibroma.
Yeah, it's a cellular angiofibroma, exactly. So you can see there's so much overlap between these things. It's kind of a bit iffy, right? But they have a lot of morphologic features that resemble each other. So we'll kind of talk about that real quick. So they are benign, right? But they do have a bit of a, they can recur locally, but they're generally benign. There has been some sarcomatous transformations described, but it's extremely rare. And then almost all of these cases happen in the kind of inguinoscrotal or vulvovaginal regions. It's pretty rare to see it elsewhere, to be honest. So generally think about the groin, right? So, like I said, it's going to have overlapping features. So bland, kind of fibroblastic type cells, kind of more delicate looking collagenous fibers rather than ropey, though. And they're more like numerous kind of small to medium sized thick walled vessels that run through. And again, you can have the same sort of deal. You have like variable adipose tissue, you can have some plastic changes. These things are generally 34 positive. Desmond and SMA are less common, but they can be, right? And they will have loss of RB1. So again, they're another RB tumor, right? And then I didn't pick up a slide for this one, but this is another one in the RB tumor, right? So we're kind of running into like, these are all the RB tumors here. It's called acrofibromyxoma, right? These are benign. And they do have some local recurrent potential. These tend to be more like around the fingers, usually periungual, where the vast majority of them are. So they'll be more dermal based. They're more skin lesion, right? And they're going to have more variably myxoid to collagenous features overall. But again, they'll be 34 and they'll have loss of RB1. I think I have an example of one here from, let's see. I have one from Path Presenter for us, for example, here. You can see again more variably myxoid to collagenous looking. These kind of like thin walled vessels running throughout, but they're generally fairly kind of like ill-defined nodular within the dermis, right? So RB is a good marker, and it's about half of them I say that actually lose it, but it's a good marker. All right, here we go. So here's your summary slide on RB1, right? RB1 is kind of interesting. This sort of an expanding subset of tumors that are RB1 lost. So we talked about spindle cell lipomas in that first lecture. Myofibroblastomas, cellular angiofibromas, we think of these things almost like in a spectrum because they have sort of overlapping features, although they're distinct tumors. The other things that can be RB1 lost are pleomorphic liposarcomas or atypical spindle cell / pleomorphic lipomatous tumor, which refer back to that lipomatous lecture for that. A dipstick lecture. It's useful to kind of think about the locations. Thing is, like spindle cell lipoma, we talked about often kind of like the upper back, posterior neck, older patients. To be honest, I've seen them everywhere. But more often than not, they're kind of up there. With cellular angiofibroma and myofibroblastoma, they tend to have very particular locations. So it's useful to kind of make those distinctions there. And same with acrofibromyxoma. Tends to be in the digits, can be sometimes in like the forearms or the legs or something, but it's usually it's in acral extremities. Okay. Sweet. All right. Moving on. Okay. Oh, we have one other tumor here that sometimes I always feel like it falls into the same features just because it's another groin lesion, but these are not RB1 loss, and I believe I do have a picture of it later, but we'll get to that in a sec. So Angiomyofibroblastoma, these are benign tumors, and they pretty much always are in the like perineal area. So usually in the subcutaneous tissues, mostly in the vulva most of the time, but sometimes they arise kind of in the vagina, or they can arise kind of even within the gynae tract, but most of the time they're sort of a subcutaneous tissue. Pretty much most are in women. There are some rare examples in men, and they tend to happen around the scrotum or peritesticular area. So they have a very interesting look, but classically they're Desmond positive and ERPR, so that's very helpful, but they're often negative for SMA. So here's an example. They're generally very hypervascular, so they have a lot of vessels, and then they have these kind of ovoid to round looking cells that kind of usually surround the vessels. In these sort of like delicate cords that surround vessels. So that's kind of what angiomyofibroblasoma looks like. Again, I don't tend to see a whole lot of these personally just because it's more diagnosed by GYN. So, but I figured I'd put it in here. Okay. All right. We have a couple more slides to go, I think. Let's take a look at another one here. All right. Here we are. We have a core biopsy, and I'll bring this down here and we can take a look at it. What do you guys think?
Kind of have this highly nice background. And then
Okay,
we do have,
hyalinized is true. Yeah, it's kind of myxoid to hyalinized in the
Yep.
background.
yeah, and then looking at these cells, they kind of spin the cells. They have this eosinophilic cytoplasm.
Which ones? You're talking about sort of the intervening stuff here?
Yeah,
Okay, there's a couple.
I wonder if these
Oh yeah.
vessels are like chicken wire.
Yeah, there's a bunch of vessels here. Yeah, it's kind of like chicken wire you can use. You can use arborizing. There's if you want to, I, as to be as pretentious as possible, and I love doing that. But chicken wire, yeah, it's sort of like a very thin, delicate capillary vasculature running throughout this, right?
Yeah.
It's very dense, honestly, with it. That's very important, right? Okay, what else? Anything else?
has this fibrous background or highly nice background.
Yeah, it's kind of fibrous. There's a couple of bigger cells as well throughout here,
Yeah.
or
Yeah,
bigger vessels, but mostly a lot of vascular tissue.
yeah.
I think I'm mixing up the vessel cells with the other like cells within the stroma. Can you just point out a few like of the vessel cells?
Yeah, it's a good point, right? So how much of this is not, how much of these are endothelial cells and how much of this is like stromal tissue? That's a good question. All right, endothelial cells, right?
Yeah.
Endothelial cells, but also
Yeah.
this, all
Yeah.
these. To be honest, it's all predominantly endothelial cells, right?
Oh, okay.
So this is the thing. This lesion generally has pretty innumerable, like tiny little thin-walled capillaries running throughout it, which where this thing gets its name from. So there's generally maybe there can be some of these like loose stromal cells in between. Okay. Does anyone know what this is? It's kind of a weird tumor.
Yeah, I think it's angiofibroma of soft tissue.
Yeah, exactly. It's an example of an angiofibroma of soft tissue. And although we've talked about angiofibroma before, it's kind of a nomenclature thing because generally we're extremely bad at naming things. So
Right.
we'll talk about that in a second. But here we go. Yeah, so this is called an angiofibroma soft tissue. So it's a benign tumor, right? This is its own distinct tumor in the soft tissue. It's benign, but it can be somewhat multinodular to like infiltrative at times, and it can kind of push into adjacent tissues. Usually it's in the extremities, most often kind of sub-Q, but can be deep. Can sometimes kind of sit on the fascial plane and extend along the fascia. And it happens at any age generally. But the big thing here is that there's lots of different angiofibromas that we talk about. And they're all different from this one, right? So we talked about cellular angiofibroma already, which is its own tumor, the RB1 loss tumor. There's also nasal angiofibroma, those patients that kind of usually in boys, AR, they're AR positive, that kind of thing. Those happen within the sinonasal tract. And then there's also skin angiofibromas, which are called fibrous papules. They all have different names, but they're all different from this tumor. So just kind of keep that in mind. All right, so the criteria here, innumerable thin-walled branching vessels that we see, and then it's generally a myxoid to collagenous stroma with kind of like these bland spindle cells. Perivascular ionization is pretty typical, as well as inflammation. We did see some inflammation throughout here as well. They are variably kind of like 34 in EMA. It's not, stains are not super useful, but if you want to highlight all the vessels, you can. But classic, right? They have a fusion. So that's why this is its own thing, right? Its own tumor. So it's an HRR and COA2 fusion. It's one particular one, right? All right, any questions about angiofibroma? Cool. Sweet. It's a weird tumor for sure. Certainly a weird tumor. All right, let's see what is next. Oop. Okay, so let's start with this one. Okay, this is probably going to be maybe our last one today, I think. But let's see. All right, so we have a kind of a sub-Q based lesion, looks like. All right, so what do you think about architecturally? What's going on here?
Like vaguely lobular.
Yeah, it's kind of lobular to
Mm.
multinodular, kind of ill-defined, kind of does extend out to here as well into the soft tissues. Okay. I guess I can point that out there. Okay, so let's take a look at the architecture of this area. What do you think?
It looks like we have this myxoid background.
Yeah, it's very myxoid. That's true.
And then I see some areas of necrosis, like here.
Necrosis, not. I
Necrosis?
think there's some kind of fibrous banding throughout, but
Uh,
not exactly necrosis here. But okay.
Lots of
What else?
cells like in a matrix and they're like evenly like placed, I guess.
Yeah, they're kind of swimming through the myxoid.
Yeah, swimming. Yeah, yeah.
Okay. All right. All right. What about the so they're kind of haphazardly kind of distributed throughout the myxoid change. What else do you notice?
curvilinear vessels.
Yeah, now we want to get into this
Yeah.
stupid curvilinear vessels. What the hell's a curvilinear vessel?
Is it a
Uh,
curve or is it a linear?
Honestly, they all look linear.
They
I don't know
all
why we
look
call them
linear. Where's the
curvilinear.
curving?
just there's a little curve right there, right?
The little angle.
I don't believe it.
It's just a bit of annoying nomenclature, but yeah, they have these kinds of like long kind of curving
Yeah,
vessels,
yeah.
right? What about cytology? Some light
Kind
there.
of hyperchromatic.
Yeah, there's a couple of atypical kind of somewhat scattered atypical cells throughout here, right?
Yeah.
Oh, yeah. That one looks dead.
Definitely some atypia, right? Here's more curvilinear vessels, right? If you want to hallucinate that. All righty. So what do you think this is? Here's a bit more of a fibrous area, but all right. Other than that, wondering about low-grade fibromyxoid. That's a
Yeah, me
good
too.
thought. That's a good thought. One big thing, though, it's true. You have these mixtures of some kind of fibrosy areas, some myxoid areas, but generally you're not going to see this level of polymorphism in a low-grade fibromyxoid.
Yeah, it looks like it's a
Um,
superficial lesion with multinodular architecture,
uh,
curvilinear vessels, and polymorphic cells.
yeah,
Putting all these together, I think of Myxofibrosarcoma.
yeah, exactly. So this is a good example. This is a Myxofibrosarc. So this is kind of that other very similar looking tumor sometimes. But the big thing here is that you will almost always have some amount of like scattered polymorphism that is kind of defining for this lesion. Um, and that's what we see here. So this kind of like scattered polymorphism within the myxoid change. Now this is an example of a low grade Myxofibrosarcoma. The grade generally for these things, as these things get higher grade, you start to get less myxoid change, right? So here's an example of, I believe it was like an intermediate to high grade, I think. And you can see you can see the curvilinear vessels still kind of running through the tumor, right?
Mm.
But then again, very pleomorphic spindle cells in this myxoid background that's getting much more cellular, right? And
Yeah.
then over here, like right here, for example, very myxoid, kind of lower grade component here.
Yeah.
And then over here, much more
Oh,
like a pleomorphic sarcoma, right? So as you like a high-grade tumor generally almost just looks exactly like undifferentiated pleomorphic sarcoma, right? So just a high-grade pleomorphic tumor. So that's Myxofibrosarcoma. All right, let's talk about it because it's one of the most important tumors in that we'll learn about, right? So Myxofibrosarcs, most common sarcoma in the elderly, right? So they're going to be in patients usually kind of 50s to 70s. It's extremely rare in younger patients. Anything younger than 30s, I really caution against it. It's extremely rare. Um, they're malignant. They have extremely high recurrence risk, about like 30 to 40%. Most of them will recur because it's actually quite difficult to resect these entirely. Even, really experienced surgeons, it's actually really hard to get around it. Surgeons often don't like to resect these because they can be so aggressive. So they need a very aggressive resection and adjuvant therapy, radiation, that kind of thing. The metastatic risk kind of varies, right? Low-grade tumors, low-grade mixed fibrosarcomas pretty much don't really metastasize. But high-grade tumors have a pretty decent met risk from like 20 to 35%. This is actually lower than most kind of like high-grade pleomorphic sarcomas. So it's useful to make that distinction between a myxofibrosarcoma and an undifferentiated pleomorphic sarcoma or a D-diff liposarcoma or something like that. Most myxofibrosarcomas tend to be sub-Q, actually. It's pretty typical in an old person, a sub-Q lesion that's kind of like ill-defined. Think about myxofibrosarcoma. But about a third are deep in the skeletal muscle. And they tend to be most commonly in like the lower limbs or kind of like the limb girdles, but you'll see them kind of in the extremities throughout. It's extremely rare to see a retroperitoneal example of a mixed fibrosarcoma. You really just want to be careful. You're not just dealing with D. diff liposarcoma. Okay. All right. And then histologic criteria we mostly talked about, right? So multinodular to infiltrative background. They tend, or borders, they tend to be myxoid, right? At least focally. They're spindled with at least focal pleomorphism. You need some sort of marked cytologic atypia, and then those long curvilinear vessels. The cellularity and the myxoid change, like we said, generally varies with grade. There is an epithelioid variant, so it looks very kind of round epithelioid, looks more like a carcinoma almost. That can happen. And those actually tend to be pretty aggressive. They may met to lymph nodes, so be careful with that. And IHC is not really useful for the diagnosis, and there's generally no specific molecular changes. That said, be careful about one thing, right? So myxofibrosarcoma is one of those tumors that is well known to have MDM2 amplifications in a subset. So about 15% will actually have MDM2 amplification. And that becomes a big problem, right, when you're trying to make that distinction on biopsy. And MDM2 fish by itself, it's not always 100% specific, right, in a high-grade sarcoma environment, right? That said, most of the time, these MDM2 amplifications are going to be relatively low copy number. So you'll have kind of like less than 10 copies of MDM2 per cell, but more than that, the more likely to be D. diff lipo, but most of the time, but you can see them, right? So I think I have a couple more. This is another one. I think both of these are from the same one. You can kind of see this is a high grade example, just a high grade pleomorphic sarcoma, basically, right? And if you go to the background over here, you start to see some of that background myxofibrosarcoma area, right? Here's another one from this same case, which again, a lot of it shows this high-grade pleomorphic sarc. And then there's this focus here that shows what looks to be a low-grade myxofibrosarcoma here. Thing is, this tumor was called D. diff liposarcoma at another hospital. So just be aware, right? This is not D. diff lipo, it's myxofibrosarcoma. And you can tell it's much more infiltrative than you'd expect, and there's no background well diff liposarcoma component. But it did have an MDM2 amplification, but it is actually myxofibrosarcoma. Cool. All righty. I think, let me see, that might be the last one we can get to it today. I think we have a few more later, but I think it's probably best to wait on that, and we'll
sure.
put that into part 3 the next time.
What a
Yay!
cliffhanger.
And
Oh,
what could the next one be? Could it be low grade myxoid? Myxoid flat? I don't know. Guess we'll have to figure it out next time. All right, guys. Any final questions before we call it?
No,
Yeah.
thank you.
All
Thank
right.
you so much.
Guys, thanks for sticking around. I know
Of
it's
course,
took a little bit longer today, but
totally fine.
sweet. All right, guys.
Bye.
See you next week.
Thanks.
See you.
Bye.
so
Thanks,
much.
Mars.
Bye-bye.